It's an honor to introduce Dr. Jayson Marwaha. He will be our speaker today. Dr. Jayson Marwaha is currently the Chief General Surgery Resident at Georgetown University Hospital with a focus on robotic surgery and surgical informatics. He had abundant experience building, evaluating, and deploying AI for surgery at very large academic medical centers, resulting in some highly cited publications. And he completed the NIH postdoctoral fellowship in surgery and informatics at Harvard Medical School. He is an incoming minimally invasive surgical fellow at the University of Michigan with an ongoing research in developing and deploying new digital technologies for surgery. Some of his other achievements include being an editorial board member for Nature Digital Medicine, being an editorial board member for the Journal of the American Medical Informatics Association, being a member of the American College of Surgeons Committees on Health IT, and he was nominated to be the most published and cited physician by Doximity for the last year. And he is the finalist for Forbes 30 Under 30 in healthcare in 2022. I know that there are a couple of things you might want to add or elaborate on here.
No, that's very flattering.
Okay.
The only thing is the 30 Under 30 and 2022, you kind of gave away my age a little bit.
Sorry.
About, but that's okay. No, but thank you guys for having me. Thank you, Lucy. Thank you, Dr. August. It's like I am thrilled to be here, and it's so sort of refreshing to be to like step out of the sort of echo chamber of your own discipline. Especially like in the world of surgery, you just kind of you rub shoulders with really only surgeons all day, every day, and so it's awesome to kind of interface with people doing other really, really interesting things. And I hope I hope I will be able to say something of some value to you guys that might inspire you to think a little bit more about clinical practice maybe in your work, and also I'm sure I'll gain a lot from your guys' insights too. So all right, so why don't I get started? And sorry, I have, just really quickly, for clarification's sake, I have until 5:45, right?
Yes.
Okay. Or like the whole thing runs until 5:45, I should say. I'm not going to keep you here any longer than that. Just sort of very, very quickly, some sort of technical disclosures. I'm a medical advisor for a very small sort of company that builds enterprise AI for a wide variety of sectors, and they also are building, enterprise AI for hospitals, for healthcare organizations, but it's mainly focused on sort of business analytics and operations, and I'll be talking about clinical practice, so the two, I'd say, are pretty, divorced from one another. And then the other disclosure I should mention, which I was mentioning to Lucy and the others, right before this, is that I do unfortunately do a very small amount of self-citation in the discussion I'll be having over the next hour or so. But I tried to keep it to a minimum because I think the purpose of this talk is really to try to highlight the way more brilliant minds than me that are doing work in this space too. So hopefully I'll get you guys to be introduced to some of my favorite literature from other people that I've learned from. Okay. So I kind of wanted to start with a kind of a brief question or brief proposition, which is, what if I told you that the next time you or a loved one stepped into a hospital, the type of care that you received or they received, meaning the decisions that were made about their condition, the tests that they got, the treatment that they got, was going to be as unpredictable or as random, really, as a lottery. And I know that sounds sort of jarring, but you don't need to take my word for that claim, because that claim comes actually from the 2002 Nobel Prize winner in economics, Daniel Kahneman. He published a book in, I think, 2001 called Noise, a Flaw in Human Judgment. And I remember reading it just a couple months after it came out, and it was totally transformative as far as how I thought about human decision making. Really, it's not a book about medicine or anything like that. It's a book about human decision making and sort of the very messy and imperfect ways in which humans make decisions in their everyday life in a chaotic and very complex world. And so some of the examples, actually, that some of you already might be familiar with, coming from a background in criminal justice, or that's sort of what you're studying during your degree program here, is he talks about examples like the hungry judge effect, which some of you guys may have heard of. This phenomenon where in the criminal justice system, the judges tend to acquit sort of defendants more at higher rates in the hour after the lunch break, which is one of the examples he cites early on in the book, which I think is sort of jaw-dropping. And what are some other examples? One other example he cites of insurance underwriters who charge premium, approve and deny claims one day at an 88% rate, and then the next day at a 5% rate because of external factors, and things going on in their life that have nothing to do with the facts of the claim at hand. And I think there are so many examples that he mentions of life-altering decisions that are made that are influenced by totally irrelevant factors that have nothing to do with the case at hand. And this is not just sort of this is something that I guarantee you are intimately familiar with it well. I mean, noise, these unpredictable factors played a role in what college you ended up going to, which colleges you were accepted by and rejected by, when you applied for your undergraduate degree. I mean, it pervades everything that you and I have experienced in so many areas of our life, and the decisions you make, and I make, are clouded by noise as well. And I think so. What he's referring to when he talks about, when he coins this term noise, is really the cognitive biases and the heuristics that the human brain kind of uses as a crutch when dealing with an overwhelming amount of information. And again, we live in a very messy and chaotic and complex world. We're inundated by tons of data for every big life decision we make, and so we fall on these kinds of cognitive shortcuts to help us make these kinds of decisions. And again, he mentions some healthcare examples in the book, but the book again is not about healthcare or any sector in particular. It's about sort of human decision making at large. And that being said, as I was reading the book, I obviously couldn't help but think about the examples of cognitive biases and heuristics that physicians make when they make life-altering decisions about other people multiple times a day. And so some of this has already been sort of explained in scientific, and evidence has been shed upon this sort of decision-making sort of conundrum in the literature. And one very nice example that came out very recently is this brilliant short study that came out in Science, I think a couple of years ago, called "Heuristics in the Delivery Room." And to very briefly summarize it, this researcher essentially looked at a large amount of data around how obstetricians make decisions about whether to proceed with, like, say, vaginal delivery versus C-section for any given type of for any given specific patient. And what she found is that one of the biggest factors in what type of care the physician chooses for any given patient, one of the biggest influencing factors was the outcome of the prior patient. So, like, if patient number one gets treatment number one and it didn't go so well, then patient number two is going to get treatment number two, right? And we all, this is a room full of people who are facile with data, and you guys all know that, like, these are statistically independent events, right? This has, what happens to the patient in the room next to me should not influence my care, because the facts of the scenario are very different, and the comorbidities and all the medical complexities are very different. And, this is commonly, kind of referred to in the sports world as the hot hand phenomenon. If any of you guys are like, basketball fans, like, you guys know that there's this common cognitive sort of fallacy, shortcut that we make where we think that if someone is, making a bunch of three-pointers, in a row, we think that the likelihood that they'll make the next three-pointer is even higher, but it's not. These are statistically independent events. And this is the perfect example of a heuristic, of a cognitive shortcut that we make as humans, because we are bombarded with tons of information, and we have to make sense of it somehow. And so sometimes we fall on these shortcuts, many of which are not evidence-based and don't actually play out in reality. This is one of the most amazing papers that I think I've ever read, and I'm excited to share it with you. And it also highlights another cognitive bias that comes up in surgery, but more broadly in medicine all the time, and it's called the left digit bias. So the left digit bias, as a layperson, you encounter it all the time. As you go to the grocery store and you see something that's $7.99 instead of $8, and so you kind of think of it as being a little bit cheaper, and so you buy it. So these authors essentially uncovered this phenomenon in surgery and in patient selection for surgery. So just to give you some sort of brief preface on what they studied. So coronary artery bypass graft surgery is a type of heart surgery, and it's often in some cases can be a life-saving procedure for patients who are hospitalized after an acute heart attack. And so they wanted to figure out if there were any cognitive biases that played into a surgeon's selection to operate on someone who's hospitalized with an MI, with a heart attack, or not. And obviously, as you can imagine, physicians are, when a patient is admitted to the hospital, physicians are bombarded with hundreds of thousands, easily, of data points about a given patient. Lab values, imaging studies, their medical history, intangible things like their social, things that aren't as quantifiably measurable. There's so many things that should factor into whether or not someone would benefit from surgery or not, and they wanted to see if there are any sort of irrelevant factors that play into that as well. So they took a big cohort of patients who were hospitalized across the country with myocardial infarction, and wanted to see how surgeons selected patients who should undergo CABG versus patients who didn't undergo CABG. And so this is one of the figures from their paper. You can see, on the y-axis, the percentage of patients that are selected to undergo a CABG, and then ones that aren't. So the ones that are selected are in yellow. Sorry. Sorry. It's an age cutoff between the two. But so as you can see, amongst patients who are 77 years old, who are hospitalized with an acute myocardial infarction, roughly the same number of people who are about to turn 77, like 76 at 50 weeks versus 77 in 2 weeks. The decision making is about the same, right? It doesn't really, the fact that they're almost 77 versus just turned 77 doesn't impact the surgeon's decision making all too much. Same with 78, same with 79. And then all of a sudden, when someone is 79 years old and 50 weeks, versus they just turned 80 and now they're 80 years old in 2 weeks, there is a statistically significant difference between whether this person receives life-saving care for their heart attack or not. And I think we can all sort of acknowledge, you don't have to be a doctor to know that there is no physiologic difference between someone, there's no magical thing that happens inside your body when you turn 80. That is pure cognitive bias, where you see the number on their patient's chart, and the first thing you see is they're 80 years old, and you automatically think they're too old to undergo this surgery safely. When in fact, if they had presented to the hospital just 2 weeks or 4 weeks earlier, the trajectory of their clinical care would have been radically different. And so this is what I mean when I talk about how noise clouds, our decision-making in medicine often, is that these patients, obviously, as I mentioned, are unbelievably complex, and there are so many pieces of data we can use to accurately describe their physiologic state. And whether they're 79 at 50 weeks versus 80 in 2 weeks is not something that really describes their physiologic state at all. And yet it is a statistically significant determinant of what trajectory their care will take. And so that's, I think a beautiful way to expose an area of improvement as it relates to surgical decision-making and patient care. And so, as I mentioned, these kind of examples of noise that I'm describing, ultimately boil down to cognitive biases and heuristics, which ultimately, I think, sort of are our way of coping with mechanisms for the growing complexity of medicine. With every year, with new technology and new advances in science, the number of data points we're confronted with for each patient we encounter in the hospital is growing far beyond our cognitive capacity to interpret all of it rationally. And this is kind of how I got interested in this field, because towards the end of Daniel Kahneman's book, one of the many solutions that he proposes to noise as a kind of a societal problem at large is to use algorithms. I think that the same goes for medicine. If the problem is that medicine is increasingly becoming a very high-dimensional field, the data in medicine is becoming more and more high-dimensional, then the problem really is that humans are low-dimensional thinkers, right? And so there's kind of this asymmetry between the nature of the data we're given and our ability, again, to kind of process it all very rationally. There's another perfect example is, there's historically sort of like a anecdotal reason why telephone numbers are 7 digits long, is because we're really only able to consider roughly 7 different variables in our head at once, when in fact I would argue that you cannot describe a patient's clinical condition in just 7 variables. You need, probably thousands of them. And so, the solution per Daniel Kahneman is algorithms. And so I think in medicine, clinical algorithms really are the perfect tool to adapt to this increasingly data-driven sort of age of medicine. And the reason why that he argues, and that I really agree with, is that number one, algorithms are immune to these kinds of mental shortcuts that plague human brains, right? Like, a algorithm is not going to make a different decision about a defendant 1 hour before the lunch break versus 1 hour after. It's going to make the same decision every single time. If you ask it a million times, it'll always make the same decision. Because it only considers pertinent facts to the case. That's reason number one. And then reason number two, again, is that they're designed to consider massive amounts of data all at once, which we are not. And that being said, the way I like to think about it as it relates to clinical decision making is that it sort of is a perfect complement to how we make decisions. I'm not trying to kind of criticize how we make decisions in our everyday life. I think we do incredibly valuable things, and one of those things is that we're able to capture non-quantifiable information. Like when a physician steps into a patient's room in the emergency room, we can detect things that no machine is able to detect, like patients' like their body language and things that kind of we can factor into our decision making that cannot be quantified and digested by a machine. And that's incredibly valuable. That's an incredibly valuable piece of information that you can bring to the table when it comes to bringing pertinent facts about the case to make the best decision. But of course, as I've mentioned a number of times already, algorithms have a perfectly complementary strength, and so the solution really is to bring together, I think, the best of human decision making and algorithmic or statistical prediction, really, to make the best decisions about clinical care. And algorithms, I should mention, are used, believe it or not, are used throughout healthcare every day already. They are used in for insurance claims and all sorts of things, but they're mainly used for operational purposes, not really for clinical decision making. And clinical decision making really is the final frontier. I would argue that there's really there are zero successful generalizable use cases where algorithms have safely been applied to clinical practice, and become a gold standard for deciding a patient's care. And so that's really the final frontier, and that's kind of the space that I've become most fascinated with, because the value proposition is there. And so how do you bring algorithms to the bedside to help make decisions about patients? And so what I'll try to do with the remainder of my time is kind of go into some challenges to bringing algorithms to the bedside. And so the first challenge really, I think, is building robust models. And that seems simple enough, but it kind of obviously goes, there's a lot of nuance to that challenge. I think one way to kind of to put some sort of nuance to that challenge is by describing an RCT that I recently summarized with some colleagues at one of the journals that I am a part of. And so there was a sort of review of randomized control trials that was recently published in this journal. And they essentially examined the outcome of all RCTs that they found in the literature studying machine learning-based algorithms that were deployed, in clinical care for the purpose of evaluating whether they had any kind of clinical impact or not. And what the vast majority of studies included in this review found is that there is no clinical benefit of using algorithmic prediction tools compared to the standard of care, which is shocking, mainly because if you look at the in silico, like just the sort of statistical performance of all of these models, it was generally very good, right? Like all of these RCTs studied algorithms that had been vetted with internal validation and in some rare cases external validation as well. Basically, like all of the quantifiable metrics of their performance was excellent. But then when you put it in front of doctors in the real world, they make absolutely no difference. So why is that? So I think part of the reason again comes down to building good models and what one sort of facet of building good models comes down to building one that, and this might sound kind of intuitive, but comes down to building models that tell the doctor something that they don't already know. And as simple as that sounds, it is a challenge that I would say plagues most models plagues many models that are published today. And so one I think excellent example is what's called the EPIC sepsis model. And so just a little bit of context. So EPIC is one of the biggest or maybe the biggest EHRs that is it's used by many if not most academic medical centers in the country. And they, a few years ago, built in-house a algorithm that predicted whether a patient, admitted to the hospital, was going to imminently develop sepsis or overwhelming bacterial infection or not. It's a very important condition to recognize early because the earlier you treat it, the lower the likelihood of mortality, of inpatient mortality is. So they built this algorithm thinking, with the sort of mindset of, let's help physicians identify sepsis early so that they can initiate treatment sooner. The algorithm was, deployed in Epic and for use by doctors, kind of across the country, and ultimately, unfortunately, ended up kind of getting widespread criticism for many reasons. But one of the most fascinating reasons, I think, was when researchers looked under the hood of the model. What they found is a couple of things. They found that it was most accurate 3 to 7 hours after the diagnosis of sepsis had already been made by the physician. So yes, theoretically, when the company was testing their model in silico, before deployment, I'm sure they thought, this model's AUC, a measure of its performance, is excellent. It does a great job of identifying patients who have sepsis or will develop sepsis and ones who don't. But you only really know once you deploy in the real world whether that accurate prediction is timely at all or not, right? And if you deliver that prediction, think about being a doctor and seeing a patient and think this patient is about to develop sepsis or is going into sepsis now, I'm going to start treatment. And then 3 to 7 hours later, you have someone come tap you on the shoulder and say, hey, I think this patient might be developing sepsis, right? It's not going to change your clinical decision whatsoever or have any sort of clinical value. And in fact, it might be kind of an annoyance. And, so what they found, is that this model delivered its most accurate predictions after the physician had already ordered antibiotics, preemptively starting to treat, impending or active sepsis, and it had already ordered a lactate, which is, one of the lab values that you can check to assess if someone is developing sepsis or not. So timeliness is a key, and kind of considering the sort of real world factors around delivery of your prediction, I think is one very important factor to building a robust model. And, and one of the other criticisms that this model came under is that while it performed very well on Epic's internal data when they were training this model before deployment, when they deployed it to hospitals around the country, its performance metrics significantly decreased, right? And so this comes to the idea of another aspect of building very good models is rigorous external validation. And so, your predictive tool might do a very good job on data set number one, but, the country is incredibly diverse, and just because it performs well on, a cohort of patients in, Wisconsin, absolutely does not mean that if you try to deploy it in Arizona, it's gonna maintain its same level of accuracy because of differences in the patient population there. And so that it was also a problem that plagued that one particular model, but really plagues many models that are published. Every day, there are models published in surgical journals that I follow that purports that the model can predict XYZ, very clinically important outcome, with incredible accuracy. But, out of curiosity, a study that, a question I wanted to answer a couple of years ago was, do these published models, how do they perform on data sets that the algorithm has never seen before? And in fact, the answer is not that they perform poorly on data sets that the algorithm has never seen before, but most authors actually don't even check how it performs on external cohorts that the model has never learned from before. And that's the real nature of deploying these models in practice, is they're most valuable when they deliver predictions on patients that they are one very sort of valuable feature of them is that they should ideally be able to see a patient that they've never been trained on before and come up with a clinically accurate prediction. In fact, that's not something that most researchers regularly check for when they publish their paper. And so it can kind of lead to misleading findings where you think that model is, again, in silico very robust, and then you try to deploy it in the real world, and you realize that it's very good at telling you what will happen to patients it's learned from, but it's not very good at telling you anything about the patient sitting in front of you in clinic or in the hospital. And so, that's sort of one kind of relatively technical challenge is build a good model from the beginning. Externally validate it, make sure that what you're predicting is clinically useful and is telling the physician something that they don't already know, and you're telling them that in a timely manner. And I think that as far as solutions go to this, I think one solution is really one solution falls on researchers and falls on journals to kind of set clear standards for what kind of models are worthy of publication, and sort of set minimum standards for ones that are worthy of publication. And those minimum standards should include some level of external validation and baseline adherence to baseline model design standards, which sort of have already been published. And then the other, I think, outside of researchers and journals kind of taking this on themselves, I think that to some degree this falls on regulators as well. I hear about I'm sure every day in the news we all hear about news around regulators debating how best to regulate AI that makes it into the real world, whether it's AI for healthcare or AI for self-driving cars or what have you. And I don't think that anyone has really figured out the answer to it. But I think what we need is baseline standards in healthcare for model safety and model equity. And those kind of standards need to kind of come from and be enforced by regulators. And I would say that as far as the precedent goes, when EHRs were first rolled out, many years ago, the federal government did an excellent job of setting up national hotspot centers where EHRs were rigorously tested and validated before they were more widely deployed. I think we kind of need to follow a similar example and sort of designate national sort of centers where algorithms are very, very rigorously vetted and tested before they kind of get deployed into the real world. So that's one challenge. The second is, okay, so you've built a great model. You're a part of a research lab. You've built a great model. You've externally validated it. You have asked a bunch of doctors their opinion of it, and they think it's great. Now you need to get it into a hospital into a physician's workflow. And this is kind of I'd argue this is probably the most technical and maybe least interesting challenge, but it's incredibly important. And the reason why I say it is because deploying models in an academic medical center, which is sort of the clinical setting that I'm most familiar with, is an unbelievable technical and organizational feat. And I'll kind of zoom through this challenge real quick, but in my limited experience, trying to deploy models that we've built, what you find is that it's not as easy as just sort of building it and then these models aren't plug and play. In part because of how complex the health data ecosystem is of a hospital, right? The sort of clinical sort of data warehouses that are the underpinnings of every electronic health record are unbelievably complex and don't maybe necessarily line up with the structure of the data set you use to build your model in the lab. And so kind of the complexity of that is, is a feat, to kind of overcome. And even if you do manage to overcome the complexity of the health data ecosystem in your hospital, you also have to overcome the interpersonal complexity of the hospital as well, right? There are so many kind of stakeholders you need to make sure are invested in deploying the tool, and the hospital leadership has to be on board as well. And so basically we kind of came up with, in our limited experience building and deploying tools, we came up with 9 kind of elements of that you have to consider when you deploy a tool. One is product selection, meaning like, do you build solicit labs within your university to build a model, or do you buy one from a third-party vendor? Like, where does the model come from? Does the model deliver financial value? And it might bring incredible clinical value, but this is the real world, and it has to deliver some amount of financial value too, in the form of either like cost saving or avoiding sort of regulatory fines and fees for the hospital. Otherwise, where's the impetus to dedicate resources to getting it deployed into clinical practice? It has to have clinical value. It has to improve outcomes. Otherwise, what's the point in deploying it? Do you have the right data assets? And this goes to like what I was mentioning. Do you about the clinical data warehouse? Like, do you have the right data elements in your hospital to feed to the algorithm? And then you need all kinds of like buy-in from departmental champions and executive sponsors and all sorts of things. So it's a lot more complex than just building a good model. And even beyond that, one kind of example that we learned from when we were when we were trying to deploy models is actually one that we borrowed from the private sector. There are a lot of big companies like LinkedIn and all these sort of like tech companies that have also realized that it's not just as easy as having one of your engineers build like a cool model and then deploy and then pushing it forward to production. You have to kind of there is incredible complexity in translating a model that's been built like in a lab or in a research part of your organization and putting it forth into consumers. And so what a lot of companies have done is built entirely new ML ops or machine learning operations like departments or like parts of their company. And obviously the same doesn't exist for healthcare. We don't have dedicated teams of people in any hospital that are experts in taking promising tools that research labs and companies have built and translating them into practice. But really, I think that's what you need is people who sit in this gray space right here. Like, you could build an excellent model, you could get institutional support for it, but you need, at the end of the day, you need engineers who are experts in making sure that that it actually works. And so here are just some kind of very brief examples of the unbelievably nitty-gritty questions that deploying a tool entails. One example might be like, so one challenge that we struggled with in deploying some models was like, our model needs a certain piece of data about a given patient in order to generate a prediction. Where in this hospital's many databases and tables does this piece of information this piece of data even sit? Like, it sounds like such a mundane question, but it's something that might take months to figure out. And even when you build the model and deploy it, who's going to access the prediction? Is it a surgeon sitting in the office, or is it a surgeon in the operating room, or is it a other kind of physician in sitting in clinic? And do they have permissions? Do they have the right IT permissions to access the prediction? And so there are like all these unbelievably complex questions that you have to face when deploying these tools. I'll skip over this for time's sake. But this is just an example of one of the models we built where we had to overcome like a shockingly simple sounding but actually very complex deployment challenge. And the third challenge and the final challenge that I'll mention is the challenge of so we've talked about building good models. We've talked about the sort of IT complexity of deploying these models and getting them into clinical workflow so a physician can actually see the model with their own eyes and see the prediction and use it. And then the third, which I think is the most fascinating but the one with the least obvious solution, is understanding the human AI interface. And what essentially I think this boils down to is how the question of how do you bring together the best of human intuition, the ultimate question that Daniel Kahneman asked, which is how do you bring together the best of human intuition with statistical predictions to make the best possible decision about a patient's care. And so, as a very quick sort of preface to this challenge, I kind of wanted there a couple of years ago when I first kind of became fascinated with this topic. I wanted to kind of study human intuition as it really and how it sort of compares to statistical risk prediction for surgical patients. And so one of the first studies we did on this topic was kind of survey surgeons before they're about to start an operation and kind of get a sense of their rough intuition as to how a patient will ultimately do after surgery. And then at the same time, we took this patient's clinical data, like their lab values and their imaging and all those sorts of things about them and their comorbidities. And we had sort of two different sources of data, and we used them in varying combinations to predict how a patient ultimately would do after surgery. Would they experience complications or not? And what we found was kind of interesting, which is that a prediction tool based on just preoperative quantifiable clinical data did a very good job in predicting what will happen to patients after surgery. Human surgeon intuition alone actually did a reasonably good job too, but statistically not as good as data alone. And then when you combined intuition and clinical data, the addition of intuition to the clinical data did not improve the prediction. Like the machine had already captured and understood all of what the human could contribute to the conversation about what would ultimately happen to the patient. And so then the question ultimately becomes, what is the real value of intuition, and where does intuition truly add value in predicting how patients will do and how to care for them? And actually, what we sort of found in a forthcoming sort of study is that where surgeon intuition actually does have value is in understanding what happens in the operating room. Right, the operating room is kind of a black box, and surgeons kind of finish up the case with some rough intuition of what the patient looked like, on the inside and how bad the infection was or what have you, or how bad the disease was. And that's not yet something that machines can understand or capture. I mean, one day they, I think, eventually will, but that's sort of where the contribution of human intuition, at least for now, lies, is in combining a surgeon's intuition of what happened to the patient during the operation with some objective measures of their physiologic state from lab values, imaging, et cetera, et cetera. And when you bring those two together, then you can predict with the most accuracy what ultimately will happen to the patient after surgery. One very similar study that was done that kind of also describes this human-AI interface is this fascinating study done by a different research group, also surgeons, where they took a similar algorithm that they designed that predict what will happen to patients after surgery, and compared it against physicians' predictions, surgeons' predictions of what will happen after surgery. And when you compare the calculator's prediction versus the human prediction, in most cases the algorithm does a much better job than the human in predicting what will happen to the patient after surgery. But then when you give the algorithm's output to the physician and ask them to reconsider what will ultimately happen to the patient, in most cases the physician does not change their mind, and it does not improve the accuracy of the human as a decision maker, which is funny and kind of, in some degree I can relate to it in the sense that surgeons are stubborn and you try to tell them one thing and they don't change their minds. So that kind of highlights this kind of complex interplay between human decision-making and statistical predictions, in the sense that you could have an amazingly accurate model, but then you have to filter it through a human's assessment of that prediction to get the real-world sort of effect. And the opposite phenomenon actually also has been described in the literature. So if we now have examples of humans not listening to the algorithm even when it's correct, we have the opposite phenomenon, bear out in literature as well, where when you have an algorithm give the wrong prediction to a physician, in this case a radiologist, it actually their performance, their decision making significantly deteriorates, right? So now you have them sort of on this susceptible to what other people call automation bias, where they just see what the algorithm says and they're like, oh, the algorithm, I have faith in the algorithm, it must be correct. Boom, and then they make the wrong decision. And so in those cases, like in some sense, you're overly relying on the algorithm, and that also can adversely affect patient care because they make the wrong decision. And so I think the sort of the conclusion really from all of this is that humans, physicians, respond to recommendations from these algorithms in very, very heterogeneous and messy and unpredictable ways, which is a huge barrier to translating even the best algorithms into real-world behavioral change, into real-world practice. And so, how do you fix this? Well, other people have proposed that we need to start teaching early career physicians, or like people in medical students, about algorithms in medical school. And I think this is part of the answer. What these authors described is that we need to kind of shift the way we think about medicine from a purely pathophysiologic reasoning, like understanding how cells work and that kind of, and that way of thinking, to also add probabilistic reasoning, right? In medical school, they teach you all these things about biochemistry and the natural history of disease, but what they don't teach you is probabilistically how to update your thinking based on new data. Like they don't teach you Bayesian thinking in medical school, and that's ultimately, medicine is becoming increasingly data driven, as I've said many times, and so future physicians will need to have some understanding of how to incorporate probabilistic thinking into their decision making. And then the final, I think, sort of proposed solution that I have to adapt to envisioning how humans will work with algorithms in the future to make decisions about patient care is kind of analogous to the rise of how radiologists first became a specialty in medicine, right? If you think about what radiologists do, you have these incredibly complex machines, CT scanners, MRIs, that output data, that output pixels, right? That output pictures. And those have without any kind of human interpretation, that output has no clinical meaning. It's just pictures. It doesn't really say anything about what's going to happen to a patient or what the current state of the patient is or not. And so what ultimately needed to happen what gave rise to radiologists is the radiologists functionally serve as human intermediaries between the machine and its complex quantitative output and some amount of clinical relevance. Like radiologists functionally take the output from these machines and turn it into something that is clinically relevant. And the same is true of algorithms. Algorithms are no less complex than CT scanners and MRI machines. And so ultimately what I think we'll need in the future, as more and more algorithms kind of populate in physician workflows, is some sort of human intermediary, someone who has some clinical knowledge and also some data science knowledge, who can interpret the complex outputs of these tools and translate them at the point of care, in a specific clinical scenario, almost like a consultant does, not an industry consultant, but like a medical consultant does, into something that is clinically actionable and can recommend something to the physician who's ultimately making the decision. So this is kind of a neat quote from a popular internet psychologist, internet philosopher whose videos and books and things I've read and watched. But I think there's a lot of parallels to this in medicine as well. We have these incredibly complex and sophisticated tools that people are developing more and more. Yet there are big holes in our understanding of how to use this technology for good patient care. And yes, part of the answer, I think, is to start learning about algorithms more and more in medical school and how this technology works, and teaching future physicians to work with it, work side by side with it. But ultimately, we also need to understand how we work. We need to understand our intuition better. And I think ultimately what we'll need is an entirely new workforce of physician specialists who can help kind of usher these technologies into this new sort of era of medicine safely. Thank you.
Any questions you want to ask?
That was really interesting. I have a question on like the EPIC sepsis model example that you gave. So I don't really know how like medical systems work in other countries, especially those with standardized healthcare systems, but like it seems like retrofitting models that work in one hospital or data set and like the lack of it fitting in other hospitals or data sets seems to be an issue. So do you think that wouldn't be the problem if there's like standardized like collection of data and like care in general across hospitals and care systems?
That's a really good question. So yes and no, both yes and no. And the yes is sort of an intuitive answer. Yes, when you think about healthcare systems like the one they have in the UK, where not only is it sort of standardized from a payer-provider sort of healthcare delivery perspective, but as a result, from a data science perspective, it's also standardized in the sense that researchers can access data on a national level much more easily. I would argue intuitively it is very beneficial for these kinds of studies and building these kinds of models. The challenge, though, is that what I should mention as it relates to the EPIC sepsis model is, so EPIC is deployed across the United States, and actually you could argue that it sort of has, access to a very representative sample of the United States, right? Data on, patients kind of across the country. And that's ultimately what they ended up training their models on, is they ended up training it on nationally, what ostensibly seems like nationally representative data. But I think what the flaw that it exposes is that when you take nationally representative data and you apply it to niche populations, like if you all of a sudden decide you want to apply it to one VA hospital or the VA population, at large, or the IHS population at large, or even a population in, Texas or something like that. Like, that's where it exposes its shortcomings. And so the solution that people, sort of much smarter than I have proposed is that you sort of need to, it's like sort of a basic science solution, and it comes down to this sort of practice called transfer learning, where you might train your initial iteration of the model on nationally representative data, and then you take the weights and the sort of preserve some element of that original generalizable model, and you tweak it ever so slightly to your local population. And there are many people who've done, data scientists, healthcare data scientists who've done work on showing the value of transfer learning as it relates to deploying algorithms to special populations. And I think the sort of concept that it highlights is that no matter what data set you train your model on, there will always be a population that is at the fringes of that will be outside your distribution. And so you have to be very mindful when you deploy your model in those settings that you need to adapt your model somehow to.
Or that's where intuition would come in.
I'm sorry?
Or that's where intuition would come in.
Yeah, that's actually a good point. I think there's maybe a role for intuition to play some. There's maybe a role for that intuition can play in transfer learning too.
Any other questions?
I was just wondering, it seems like AI is like a controversial topic, and people in lower wage jobs worry about their job security with it. Do you ever, I know it's a much more complex position, do you ever run into that fear with people in healthcare?
So the answer is no, I don't. But I'm trying to think of. I'm trying to kind of think about. Trying to maybe hopefully be able to clearly articulate the reason why. So I think there's a couple of reasons. So there's this common. I don't actually know the data behind this, but there's this common thing that people refer to when this question is asked, which is there was all this controversy around ATMs when they were first deployed in the United States to whether they would eliminate bank tellers' jobs. And since the rollout of ATMs, which are now on every street corner, the number of bank teller positions in the U.S. has actually increased, and that's presumably because who knows why, but that's presumably because now people have way more touch points with the banking system, and the nature of a bank teller's job has also evolved. And the same is undoubtedly true in medicine. It's no different from really any other field in that respect. I would say you could argue that when CT scanners and MRI, and maybe there was controversy around there, around deploying them in clinical practice, whenever they were, last century. But I'm sure there was a controversy around the deployment of CT scanners and MRIs and how they might supplant physician decision making altogether, when in fact they, A, I would argue, make your decision making better, and B, you've given rise to a whole new specialty of physicians, right? So those are some examples, and now to distill those examples to a few lessons, I would say, whenever you introduce these kinds of new technologies, you don't eliminate jobs, you eliminate roles but not jobs. You instead upskill people in ways that maybe you hadn't anticipated in the future. And I would say one example that's very relevant to my work is people always ask me do you think surgical robotics will replace will replace surgeons? And the answer is very personally, the answer is no. In fact, surgical robotics has created an entirely new job for me. I'm going to be specializing in the interface of human surgeons plus robotic surgeons in some degree in my job starting next year. And so, no, I think that these new technologies really only augment our capabilities. Yeah.
Okay, I was thinking of medical